Welcome, everyone. We are so glad that you're taking time out of your day to join us. We have a great webinar today with Diane Bigler on interventions for self-harm. If you feel comfortable, please introduce yourself in the chat. Let us know where you're joining us from. And just so you know, the slides and the handouts are available in the handout tab. Diane Bigler is back to join us again. She has 20 plus years of experience in mental health, social work, and criminal justice, including work with the FBI and Crimes Against Minors Task Force. She's a national speaker, an award-winning educator with a passion for creating engaging, skill-building trainings for diverse audiences. She's a former performance solutions director and an executive coach, specializing in leadership development, emotional intelligence, and team dynamics. So, welcome, Diane, again. We're so glad to have you here. And please, the stage is all yours.
Thank you so much, Angela. It's always such a pleasure to be invited back to be with you all today. Good morning, everyone. Helpers, so glad that you all are joining us today for this 1 hour presentation on assessing and treating self-harm. We are going to hit kind of the highlights of what I hope will be very useful information for you and also some very valuable resources so that you can continue to support your clients that are struggling with, especially non-suicidal self-injury is going to be our focus today. As Angela mentioned, you have 3 different resources available in the handout kind of tab. The first one's going to be the slides. The second one is going to be the handouts. Many great handouts in that handout packet, so I definitely encourage you to download that. And then the third one is going to be the resource links, which is going to have all of the links that are in today's PowerPoint, in addition to some additional deeper dive resources for you to be able, after our webinar, to go and learn more about how we can support clients in addressing non-suicidal self-injury. So check out those three documents in handouts. As you see our learning objectives here on the screen, we're going to briefly talk about risk factors and also how we can assess for self-harm. You have been provided with several assessments in your handout packet. And so I'm just going to briefly mention some of the key questions that will help us begin to assess NSSI. We will then look at interventions, treatments. And given that we just have an hour, I'm just going to highlight those. And I've also included some handouts for you to get more of an idea of what those interventions might look like. Love to see everybody saying good morning in the chat. And of course, if you have any questions along the way, please feel free to share those as well. I'd like to start by reading our opening vignette here to give you an idea of some of the common ways in which we may see self-harm presenting itself in our clients. This is Mary. Mary is a 15-year-old high school student with no previous psychiatric history. She was brought to the emergency department by her parents because of self-inflicted lacerations on her arms. During the assessment, Mary revealed to the clinical social worker that she had been cutting herself 1 to 2 times a week for several months. In the past year, Mary had experienced episodes of intense sadness and anxiety. She had learned about self-cutting through social media outlets. She also said her peers were using this strategy to manage stress. Mary reported that cutting served to numb her feelings and described it as the only thing that helps. Mary reported that about 8 months ago, she had thoughts of wanting to die and took 5 pills from the medicine cabinet. The next morning, she woke up feeling fine and told no one about the incident until now. She denied any current suicide attempts, but reported occasionally wishing that she had not been born. So I'd love to hear from you all. What do you hear in Mary's vignette that really helps us understand some of the etiology of self-injury? What are the things that are just jumping out to you with regard to Mary and how she's now found herself in this place of actively self-injuring on a regular basis? What would you like to share with the group that you think is impressionable from her story? Yes. Thank you, Kayla. Deny suicide and then coping skill. So, Mary believes that self harming is the only thing that will help. And that is really important because if our clients view that a maladaptive strategy is the only thing that helps, that may help us be able to support them in developing other things that actually might help other than the self injury itself. Also, thank you, Carrie. You said yes, the social media influence, especially with our youth, we need to be very attuned and aware, as we see with Mary, the influence of how easy it is now to go online and to find videos and descriptions and even encouragement of self injury. And that is exactly what Mary did, as well as being influenced by her peers, which we know is common in adolescence. But in this particular case, that combination of the social media influence and the friend influence really fueled her desirability and her encouragement within herself to use self harm as a coping mechanism. It is alarming, Joanne, and I think that's why if we're working with youth, if any of you are working with youth, we really need to be asking them, what are they researching online? What are they curious about that they have found out information online? Because the internet is a never-ending treasure trove of good things, but sometimes not so good things that can definitely influence our youth. The other thing that we notice here, kind of Maribel, along with what you just said, is this depression that also there's some suicidality that we see. Mary had a previous attempt. She'd never disclosed. A few of you are also mentioning the shame and the secrecy. And those are things that we want to be very sensitive to with self injury and also with suicide attempts, that many people may feel a sense of shame. And so our person-centered way of engaging with them, asking them questions in a sensitive way really goes a long way to helping them feel comfortable to make these disclosures to us. Thank you so much. Eli, you said occasionally wishing that she had not been born. Not necessarily saying she wants to die, but definitely some thwarted belonging there, maybe some hopelessness, really feeling as though even though Mary may not be directly suicidal right now, we're still somewhat concerned about that statement because it indicates that she may not feel that she has a place or a space in society, in her family, in life. So that would be interesting to explore therapeutically as we continue to work with Mary. And as you said, Jocelyn, there can be influences in the hospital as well when patients, clients are in the hospital and are influencing each other, sometimes in good ways, but sometimes in not very safe ways as well. So, one of the things that I wanted to share was, as we saw with Mary, sometimes there are elements and there are little kind of themes of death, dying, wishing I hadn't been born, previous suicide attempts within individuals that are self injuring. Just wanted to share that there's generally 4 different categories that we identify whenever we're talking about suicide and or self-harm. The first one is suicide. And these are individuals that have expressed or have communicated some level of a desire to act on a suicidal urge. A good majority of clients may not want to die, but they can also be suicidal at the same time. Suicide is not always motivated by a desire to die. It's often motivated by a desire of escapism, a desire of relief, a desire of I'm a burden to others. And so killing myself would relieve others of this burden. Very important to realize that a good number of people that are suicidal express that they don't actually want to die, but they don't see any other ways out. A completed suicide, of course, is when a client dies by suicide, which is something that we are consistently trying to prevent, decrease, and avoid. A suicide attempt, similar to what Mary disclosed to the clinical social worker, is when somebody intentionally has an intention of ending their life. And as we saw with Mary, took some pills, never shared that with anyone, is just now sharing it. And then suicidal ideation is the thoughts, the emotions, the somatic experiences of suicide that often leads to what Aaron Beck called the suicide mode, that synchronous interaction between emotions, thoughts, physiology, behavior, and motivation. And then finally, non-suicidal self-injury, which is when individuals intentionally harm, destroy their body, change the way that their body looks because of the stress, the anxiety, or other types of difficult emotional experiences or distress that they are experiencing. Key point here is that people can engage in non-suicidal self-injury and be suicidal. It's also true that people can engage in non-suicidal self-injury and not be suicidal. So both of those possibilities exist. Our goal is to determine if the client that is in front of us has the presentation of both NSSI and some suicide risk, or if it's just one or the other. So they can either be mutually exclusive or they can both be present at the same time. We're going to watch a short video about a young woman named Alyssa, and this is going to give you more of an idea of the complexities and dynamics of self-injury and give you a good idea of supportive people and also treatment. Angela, whenever you're ready, we can play the video.
Well, in the beginning, I didn't really cut myself that much, but every time I did, it seemed to make me feel better. I don't know why, really. I guess it was a bit of a relief, so I kept doing it. The more upset I would get about my dad not being around or stuff at school, the more I would do it, and then pretty soon I was doing it almost every day. I hid it from everyone, even my best friend Lucy.
One day when she pulled up her sleeves, I saw her cuts. She didn't realize I'd seen them. I knew she was stressed, but cutting herself? I never would have thought she'd do that. I didn't say anything to anyone. I was worried Alyssa would be angry at me if I did.
As a mother, you don't want to think that your child is unhappy. But I knew something wasn't right. She was becoming withdrawn and her behaviour was going downhill. And her attitude was becoming so negative. Anyway, it was around then that I noticed that she had some marks on her forearm, and I knew that was a real problem. I kept trying to talk to her about it, and she'd just come up with these little excuses. Or she'd get really angry and just tell me to back off. And then I'd get really frustrated, and then out of desperation one day I just came out with it. I said, "Have you been cutting yourself? Is that why you've got these scars on your arms?" Tears started rolling down her cheeks. I think she was ashamed that I knew.
Mum was so good to talk to. She didn't make me feel stupid. She just sat and listened. Once Mum knew, I felt I could tell Lucy. And it turned out she already knew. I was so surprised. A few days later, Mum booked me in to see a counsellor. I didn't really want to go at first, but I thought I would give it a try. partly just to get her off my back, but I also knew I needed to get some help.
When Alyssa first came to see me, she was pretty uncomfortable, but that's not unusual. Talking about what's going on with someone you don't know can feel a bit strange at first, but after a while, she would begin to say more, ask more questions, and I guess become a bit curious about how things could be different for her, how she could actually give up cutting. Knowing that our sessions were confidential also helped her to open up. But because self-harm was involved, we did have a discussion early on about ensuring Alyssa stayed safe. And if I was concerned that she was at risk of serious harm, then she knew that I would need to talk to someone about it in order to keep her safe. Alyssa's cuts went deep and didn't require medical attention, but I needed to know that she was looking after them and knew what to do.
It took me a few sessions to actually start telling her stuff. But she wasn't shocked or surprised when I started talking about my cutting. In fact, she asked me lots of questions about it. She gave me some ideas of what else might help, like writing down my thoughts when I'm feeling stressed, or even just getting out of the house makes a difference. And now that I've told my mum, just talking to her really helps.
I found these sites which talk about how to help a friend who was self-harming. It's not just about telling her to stop. It's more about being there to listen when she gets stressed and making sure just to do normal stuff together.
I've really seen Alyssa change over the last few months, and I'm beginning to understand more how it all works, why Alyssa gets stressed and what makes her cut. I think the big thing for me, though, is how I can help her. If she feels overwhelmed, I just try to do things with her, even simple things like go to the movies or go for walks. Alyssa's got a long way to go, but she's on the right track, and I'm really proud of her. She knows that she can't do it on her own, but she's working really hard at it, and that takes courage. I'm really hopeful about her future now.
Alyssa is much more aware of her thinking and the impact this has on her feelings and behaviour. She's trying to reframe things in a more realistic or positive way. She's been cutting less, although that hasn't been our main focus. Our focus has been on helping her to learn new ways to deal with stress. Feelings of anger, sadness, hopelessness, and shame are hard for anyone to get a handle on. But she's begun to express some of this using words rather than relying on cutting herself. Knowing that she can ask for help when she needs it is a really important thing that she's learned.
When we hang out, we just like doing ordinary things, putting the other stuff aside for a while. We also have this deal that if I'm worried about her, I can talk to her mum.
It's a bit weird not to be cutting. Sometimes it's really hard. But the more I manage without doing it, the better I feel. And my scars, they are a part of me. And when I look at them, they remind me of how far I've come.
Young people who deliberately hurt themselves don't necessarily want to die, but it can become a way in which they cope with distress or overwhelming negative feelings, thoughts, or memories. Some stresses that might trigger self-harm include difficulties with family or close friends, school or work problems, depression, alcohol and drug use, grief, trauma, or abuse. People who self-harm don't need to work it out alone. Finding someone to talk to, a local doctor, counsellor, Headspace or eHeadspace, or a confidential helpline is a great place to start. Self-harm might be a way to cope for a while, but in time it is important to learn to manage difficult feelings and cope with stress in much healthier ways. If someone is thinking about suicide, they need to get help straight away. A local hospital knows how to help. All right. Welcome back, everyone. I hope you enjoyed that video about Alyssa's story. Would anybody like to share in the chat What stood out for you in that video that was helpful for you as a clinician to hear from Alyssa, her friend, her mom, and her counselor? There's one point that the counselor mentioned that I really want to emphasize is that the goal of counseling was not to get Alyssa to stop cutting or self-harming. The goal was to help her identify ways that she might be able to deal better with life, with the stresses of life. And so that is really important. We may have on our agenda that we want this client to stop self-harming, but that's really not our first goal. Our first goal is to support the client in exploring their points of distress and how that stress affects their feelings, their thoughts, their body, their relationships, and then being able to develop strategies in a direction that supports coping, distress tolerance, all of those things. And what we usually find is by approaching things that way, rather than focusing on, we've got to get this client to stop cutting or self-injuring, that is going to be a much better approach, is focus on the sources of distress and how it might be an option to manage those. Let me see what you all are sharing here in the chat. Yes. Mendoza, you also mentioned that was a really important point as well. And then Michaela, you said building natural supports. You heard some elements of CBT, DBT, help the client embrace their scars during and after recovery. Joanne, as you heard Alyssa saying in the video as well. And then Deanna, the people in her life not knowing how to approach her. And you heard that she said her friend already knew. Sometimes people know in the client's life, but they don't know how to bring it up. And sometimes people don't know, like Alyssa's mom, who wondered and asked Alyssa directly. And then Alyssa admitted that she had been self-injuring. Yes, Karen, you said giving the client a voice. You also heard that initially Alyssa was not very open in counseling, but because the counselor really built that good rapport and created that psychological safety, Alyssa felt more comfortable and more vulnerable to open up about her own patterns of self-injury and what she might want and need some help with. Wonderful. Thank you, Tanya. And yes, without shaming the client in Ebony. What hurt my heart was her harming herself, taking pills and waking up without telling anyone. Yes. And then we have a supportive parent here. Not all of our clients have supportive people in their lives, so that may make treatment a little bit more difficult. Really valuable to have at least one supportive person. So how might you help your client identify the supportive people in their lives? You also heard in the video some of the most common reasons why people self-injure. So this just gives you more of an idea here so that we as mental health professionals have the context. What draws people into self-injury? And by the way, self-injury can be not just cutting, it could be burning, it could be head banging, it could be depriving oneself of basic needs such as sleep, food, etc. So there's many different forms of self-injury. The most common one is cutting. That's the one we often hear about the most. And you can see here that part of what we want to help uncover and discover is what might be this client's unique motivations that draw them more into self-injury. And so this gives you an idea of the most common motivations that we often see for NSSI. Thank you, Hilda. The importance of identifying early on when confidentiality will need to be broken to keep Alyssa safe. Very good point. Yes, and also piercings, especially piercings that are not done in a safe way or are done impulsively or create injury to the body, whereas a safe piercing is not supposed to create injury to the body necessarily. That's a good example. Also, in 2013, NSSI was included in the DSM So I've included in your handouts the official kind of diagnostic criteria required for that NSSI diagnosis. So feel free to check that out in your handouts. How many of you have either heard or not heard of the NSSI Bill of Rights? This is a wonderful way to start your work with a client that you've identified there is some self-injury. We're always wanting to be person-centered, affirming, strengths-based with our clients. And this was developed by David Martinson in 2007. David Martinson created the Non-Suicidal Self-Injury Bill of Rights. Oftentimes when I do this training, there's many people in the audience that have not heard of these. So let's review these just so that we can have an idea of how affirming and necessary these are to share with the client as we're beginning work around non-suicidal self-injury. The first one, the right to caring, humane medical treatment. The right to participate fully in decisions about emergency psychiatric treatment. The right to body privacy. The right to have the feelings behind the NSSI validated. The right to disclose to whom they choose only what they choose. The right to choose what coping mechanisms they will use. The right to have care providers who do not allow their feelings about NSSI to distort the therapy. The right to have the role NSSI has played as a coping mechanism validated. The right not to be automatically considered a dangerous person simply because of NSSI, and the right to have self-injury regarded as an attempt to communicate, not manipulate. So I invite you to share in the chat, are there any of these rights that David created that you think are really very helpful, that you've never heard before, that you think could really resonate with clients or resonate with you? Feel free to share in the chat box. My general way that I've used these in my work, which has involved working with clients that have engaged in NSSI. I was also a DBT therapist with clients that had borderline personality disorder. About 40% of my clients were self-injuring. So really what we find is important, especially in DBT with borderline personality disorder, is validation. And that is exactly what the NSSI Bill of Rights seeks to accomplish, is validating, normalizing, and giving the space and the voice to these points that a lot of our clients have experienced the opposite of these from family members, providers, society. So I invite you to just consider which of these rights are impressionable for you as we reviewed them. And do you have clients that maybe are self-injuring that you think introducing the NSSI Bill of Rights could be a very important therapeutic step? I love all of these, and it's hard for me to pick which ones I really like, but a lot of you are saying the last one, the right to have self-injury regarded as an attempt to communicate, not manipulate. And let's see here. Margie, you're asking, how do you include this in session? One of the ways, the way that I introduce it to clients is I say to them, I've had clients before that have told me that they have had their self-injury invalidated, criticized, they've been shamed. They haven't felt as though they have a lot of rights as somebody that is self-injuring. And the client may look at me strangely. And I say to them, what if there were some fundamental rights that you are entitled to that would help guide our work together and would help you feel as though you have supportive people that understand that you have the right to a variety of different things in your own experience of NSSI? Would you be interested in seeing what some of those rights may be? And virtually all of my clients at that point say yes. And so that is when I bring out the NSSI Bill of Rights. We usually kind of review them out loud like we just did. And I ask my client the same question. Which of these are standing out for you, client, that you're really connecting with or you'd like to talk about a little bit more? And that can really evolve into a very rich therapeutic discussion. So this is one of my favorite parts. We can have all of the interventions in the world for self-injury, but if you don't start here by affirming the rights that your client has, your interventions may be hollow in terms of not really resonating if a client is not and has not been affirmed in terms of what their rights are as an NSSI survivor. Yeah, Lizette, the right to body privacy. The reason why that's included is because one of the things we've seen is that sometimes people that are self-injuring, they are demanded by others to take their clothes off, to take their shirt off, to reveal their injuries. And we believe that people have a right to body privacy. And so that's why that is included. So there's not this feeling of violation that I have to strip down or I have to show parts of my body that I don't want to show. So, Jordan, how does the NSSI Bill of Rights change for adolescents? It really doesn't change. We still need to give adolescents all of the clarity on limitations and limitations of confidentiality. So you can do this in conjunction with doing that. You can introduce the NSSI Bill of Rights, and you can also communicate to your adolescent minor clients that they have these rights, and there may be times when you do need to involve other people, as we heard in the Alyssa video. So you can do both of those things at the same time. How do we assess for self-harm? So there's another video here that you have the link to. This is a psychiatric assessment of a psychiatrist interviewing a patient. This is going to give you really a clinical demonstration of an assessment. But here are some key areas that we should explore. As you can see here, be curious, discuss patterns in self-awareness, and discuss learning new behaviors. And so you can see some of the core things that we're needing to assess. Michaela, what if family does not recognize these rights? What I've asked family members to do before when we look at the NSSI Bill of Rights is which of these can you embrace and accept right now? Are there one or two or three of these on the list of NSSI Bill of Rights that you can commit to accepting with your loved one, who is the client? That is a starting point. We recognize that family members may not get on board with all of these, but are there one or two that the family members can say, we can align with these one or 2 points and we commit as a starting point to this one or 2 points in the NSSI Bill of Rights? These are more of a therapeutic intervention, Hilda. These have nothing to do with being accepted in court. These are more of a therapeutic, strengths-based, person-centered, affirming, validating approach before we begin the assessment and intervention of self-injury. Okay, I just wanted to mention the handouts that you have available in your handout packet to assess self-injury. You have the DSM criteria, you have the STOPS FIRE assessment, which is my favorite because it's brief, it's comprehensive enough, it allows you to capture the information you need to capture. We also have 2 additional assessments that were created by Marsha Linehan, the founder, creator of DBT. We have the FASM, and we also have the SASSY. And so I've included for you the examples. You also have the links here. These are going to be more comprehensive assessments, pretty detailed, But if you have a client that is moderately or to severely self-injuring, you probably want to do more of these detailed, longer assessments. So check those out. You have the assessments and you have these links available as well that you can go and you can look at which of these assessments might be best for your particular client. We also know that assessment is not just reading off of an assessment instrument, it's also conversation. It's also, as you heard Alyssa say, my counselor asked me a lot of questions. And that is what we need to do when we're in the assessment phase is we need to be curious. We need to have a structured way that we can conduct an assessment conversation with a client. So these are some questions that you and your client might be able to explore as you're beginning to venture onto the path of starting to look at their self-injury. What was going on in my life when I first began to injure myself? How do I feel just before I want to injure myself? What are my habits and routines? Environment can be a big factor. People, stimuli, all of these things. Let's get an idea of the client's environment, who's around, where they're at, and which environments make them feel safer or more vulnerable. Do I always feel the same emotion? Or is there diversity? Is there difference in the emotions I experience? Maybe one time I'm sad, the next time I'm angry, the next time I'm fearful. Or maybe you have clients that there's a consistent emotional theme. And how can I better deal with the situations that trigger me? This is what we're here for as clinicians, to help our clients figure out ways that they can better deal with these situations. And that's exactly what Alyssa did with her counselor and her mom and her friends' support. Oh, yes. If you need the handouts, they are on the handouts tab. So just click on that and you'll be able to get the handouts. Let's talk about treatment targets. Once we've engaged in a person-centered way with the client, if you have an opportunity to integrate the NSSI Bill of Rights and utilize that in whatever capacity the client, family members are receptive to, that is step one. Your assessment, your formulation, all of the client's severity, frequency, triggers for self-injury, all of those things you've captured in your assessment. Then we begin to identify treatment targets. So here are the most common treatment goals. So I wanted to give you all a head start in already having some treatment goals identified. We want to help clients identify and manage underlying issues. And these may extend for decades. If we look at early childhood trauma, other life experiences, that can take quite a bit of time. This may not be our first treatment goal, so these are not necessarily in order. But eventually, we're probably going to need to figure out what is that underlying current that kind of gets the self-injury pattern started. We also want to help the client learn skills to better manage distress and intense emotions, strengthen their self-image, improve relationships and social skills, because self-injury often begins to strangle a client's relationships and social skills. Self-injury is a natural way that people often begin to isolate. The more injuries they have on their body, the more scars they need to hide. They may feel as though they can't really engage in their relationships as authentically and have those social interactions, and then develop healthy problem skills. Now, these sound like they're pretty straightforward. How do we help clients do these things? And that's what we're going to talk about now. Let's talk about interventions. And I want to point out that in your handout packet, you have a couple of things here. You have the traditional safety plan. Safety planning is not just for suicide. Also, safety planning is for self-injury. We highly recommend that you do a safety plan with anybody that you've established, any client that is self-injuring. If that client is open to it, of course, but we really want to offer that safety planning as a protective measure. Safety planning is a means of harm reduction, and harm reduction is often the focus of how we provide interventions with NSSI. Because again, our goal is not to get the client to stop self-injuring. The goal is to help improve their safety, give them better coping skills, and ideally begin to create more space and time and mindful choice between the stimuli to self-harm and the action of self-harm. One of the favorite quotes I love to offer my clients, especially in areas like this, is this quote: between stimulus and response is the choice point. Between stimulus and response is the choice point. The response our clients choose is self-injury. We want to help them strengthen the choice point. And I want to mention there's a great video on YouTube called The Choice Point. It's a brief animated video from Acceptance and Commitment Therapy. If you would like a psychoeducation teaching tool to teach your clients about how to empower themselves with their own choice point. That is often what is lacking in impulsive behavior, is clients often go from stimulus to that reaction whenever that behavioral choice is. So the choice point is actually a skill that can create distanced space and maybe alternatives before a client automatically goes to what they've conditioned themselves to go to. Yes, the Hurt Yourself Look workbook. Hurt Yourself Less workbook, Michaela. Great workbook. I've linked that workbook on your resource links. And again, you'll find those resource links in the handouts tab. That is a wonderful workbook. And the title of that workbook speaks exactly to the principle of harm reduction. Hurt yourself less. You also have in your handout packet 31 treatment plan ideas. We reviewed some treatment plan ideas on the previous slide, but I also included a handout. These are basically interventions, 31 interventions for self-harm. It gives you as a provider a lot of options on what directions you can go in with your clients and different starting points depending on who they are and what your assessment of their self-injury is. You also have a handout on urge surfing. Urge surfing is helping clients, again, develop that choice point, riding out the wave of an urge to self-injure, distracting themselves, soothing themselves, reaching out for a connection, doing a quick intense exercise, watching a funny video. These are things that we know that if somebody can resist an urge, many urges pass within about 15 to 20 to 30 minutes. So helping the client urge surf. So recognize the urge, not give into it, but instead strengthen that choice point to do something different. You can also see on the screen, these are all of the other things that we can do around self-injury. And so we don't have time to talk about all of these in detail, but just wanted to share, for example, a hope box, shoebox, or any other kind of box. The client puts items in that are empowering, strengthening, pictures, medals, a stress ball, a fuzzy little stuffed animal. And this is their box whenever they feel that urge. And we want the client to go to the box, open it up, hold the items, connect with the items, and see if that helps move them away from that urge to self-injure. This also works very well with suicide. The Hope Box was actually created for suicidal clients. Yes, also Judy, urge surfing, the choice point, the Hope Box, All of these things very useful with substance use. Absolutely. Any type of impulsive behavior where the client goes from stimulus to their reaction or their choice, yes. Do I see, Alana, some NSSI for some people as obsession compulsion with OCD? Sometimes. So you would need to rule in or rule out, is there this co-occurring OCD? Is there some type of obsessive compulsive motivation for the self-injury, or is it more based on emotional distress in our traditional kind of self-injury? So yes, sometimes there can be the presence or the motivation to self-injure that is based on the person may actually have OCD. Okay, stages of change. You all are probably familiar with stages of change. This particular image that you see here with the arrow, this is going to give you the stages of change specific to self-injury, which I think is very valuable for us to have. As with anything else, we need to have an idea of what stage of change is our client in before we can begin to design interventions. So I wanted to share this so that you all have this as a reference. And in your assessment and your formulation, you can be deciding as your client in contemplation, preparation, action, or maintenance. Maintenance is usually considered 3 to 6 months of either significant decrease or abstinence from whatever that problematic behavior was. And then your corresponding handout here is going to be areas for growth, which is a specific self-harm assessment that I encourage you to facilitate with your clients, because it's really going to help you and them identify what are the specific areas of growth around their self-injury that may become those therapeutic targets. Yeah, I agree, Christy. These NSSI interventions can be great, and they're actually used for any other types of impulsive, risky behaviors. So whether it is excessive, unprotected, unsafe sex, drugs and alcohol, gambling, pornography, anything that is behavior-based that usually people follow that stimulus and then response. Any of these interventions are going to be great options. Okay, DBT. DBT. So, Albertina, just a quick note, the handouts, all the materials are actually available now. You just need to click on the handouts tab and you will be able to access those. So there's a lot in DBT, as I'm sure a lot of DBT is a pretty comprehensive model. We don't have the space to get into a lot of detail, so I wanted to provide you with this table. I've also copied this table for you in your resource links. So you have this as a template. You can print it. You can do whatever is helpful for you. This is going to actually identify each of the 4 areas of DBT: mindfulness, distress tolerance, interpersonal effectiveness, and emotional regulation. They're each color-coded: red, blue, green, and purple. The great thing about this particular table is it's a very user-friendly cheat sheet that helps us and the client guide themselves into which DBT skills should I try based on the particular emotion that I'm feeling. Oftentimes when you look at the DBT skills, you're like, I don't know what skills to recommend to my client if they're sad, angry, lonely, if they're physically feeling unwell. This chart is going to help you and the client direct into what DBT skills should they try first that is most going to address whatever emotional state or emotion they are feeling. So great jumpstart to DBT if you're not really sure what particular skills associate with what particular emotions. Yes, I think, Michaela, that these also could be interventions, as I mentioned, helpful with anybody that struggles with that impulsivity And that's why I recommend that video, The Choice Point, as a great point of psychoeducation, and that quote. And I actually draw that on a whiteboard for my clients. Stimulus, I draw on the left. And then response or reaction, I draw on the right. And I ask them, does it seem like this is your pattern? And they say, yeah. And I say to them, what if we put something in the middle here called the choice point? And they're like, what's the choice point? Great question. Let's talk about what the choice point is and how the choice point may be helpful in your life, whether it's drugs and alcohol, bipolar disorder, self-injury, suicide, aggression, any of these things. This is also a great teaching kind of lesson with youth as well. Very much. Thank you all for asking such great questions. Okay, a couple other things to mention here in our interventions for self-injury. There are 3 kind of areas that we know can help clients begin to stop self-destructive behaviors. The first one is giving them options to communicate alternatively. You can help your client create a collage, write a poem, journal. You can create sentence prompts and give them to your client and do that as an exercise. The other thing is release endorphins. This is going to be our somatic experiencing, right? The self-soothing, which is a common part in DBT. We have several DBT skills that are helpful with bodily regulation. And so physical activity, music, movies, anything that will allow your client in a healthy ways to release endorphins. Unfortunately, what your client has been doing with self-injury is they're releasing endorphins as they self-injure or afterwards. And they get that kind of temporary, but then it's often followed by shame, embarrassment, fear, panic because I'm bleeding. And so we want to help clients figure out other ways, healthier, more adaptive ways to release endorphins. The hug, the butterfly hug, the rocking back and forth, the hand on the forehead, looking in the room and finding something resourceful. Any of these somatic-based interventions, along with what in number 3, self-soothing. A warm blanket, listening to a guided meditation, petting an animal, praying, mantras, any of these things that connect people with the ability to both release endorphins and self-soothe. And yes, Judy, the My DBT House is a great exercise, which has the different levels of the DBT house, and you can help a client kind of work through that. Love it. The other thing that I wanted to mention, I actually want to go back here real quick. You see this stop, which is from DBT. This is also a great fundamental skill to teach your clients that have NSSI, is the stop. And so it's a very kind of structured way for them to begin to strengthen that muscle of the choice point. The other model that I greatly encourage you to check out is the CARES model. And I've given you the handout on this and what CARES stands for. Each of those letters represents one of the levels of intervention for self-injury. You also have ways of coping, DBT crisis plan, crisis survival skills, and you have a few self-injury case studies. If you're really wanting to give your brain a little bit of exercise, how would you help these clients that you see in the case studies in your handout packet? The CARES model is what I've used for years, and it's probably one of the most validated, recommended models for self-injury. And so you'll see that handout, and I think you really like what that model includes. It includes a lot of these things we talked about in 1, 2, and 3 on the slide. How many of you do chain analysis with your clients? Chain analysis is also such a valuable part of working with clients with NSSI. You can see the example chain analysis here on the right-hand side. The dark oval is when the client self-injures. But look at all of the things that happened before that. And this is what chain analysis reveals, is it reveals vulnerability factors. And you can see that this client did not arrive at self-injury just by itself. There were thoughts, there were emotions, there were environmental experiences that happened before that. And you can really begin to see how all of those are linked and how now the client is arriving at the actual behavior of self-injuring. And then, of course, we have the process afterwards as well, the shame and the embarrassment and feeling worse after they have self-injured. So your DBT Ways of Coping handout is going to give you some great ideas to help clients begin to identify the links in their chain and have ways of coping. You can also find and I think I included some links for you on your resources, the chain analysis templates. Those are just available online. Just Google chain analysis template, and there'll be many versions that come up. But this also is a fundamental part of our intervention for NSSI. Yeah, Judy, this is triggers, but in DBT, we actually call these vulnerabilities. We don't really use the word triggers as much as we do vulnerabilities, because vulnerabilities give more of an indication to the client that they have more of an ability to shift those, manage those. Triggers often has the implication that this is just something that the client is triggered by. Vulnerabilities give the client more of a behavioral opportunity to identify those vulnerabilities and try to change those. Okay, another great resource, as we have just a few more minutes here, that I wanted to mention is this. I know it looks really small on the screen now, but I've included the link for you. This is going to be a menu of many different self-injury coping mechanisms that you can see is categorized. All of these different categories. This is probably one of the best tools for you to be able to support your clients in interventions for NSSI, and you will find it at this link, which I've put into your resources. I recommend you print this, make copies of it, and have this as an available tool as you're beginning to work with your NSSI clients. And then I like to use this poem whenever we're talking about empowering clients to imagine a different future, make a different choice, and walk on a different path. This is Autobiography in 5 Short Chapters by Portia Nelson is the author. And here is the poem. Chapter 1. I walk down the street. There is a deep hole in the sidewalk. I fall in. I am lost. I am hopeless. It isn't my fault. It takes forever to find a way out. Chapter 2. I walk down the same street. There is a deep hole in the sidewalk. I pretend I don't see it. I fall in again. I can't believe I am in the same place, but it isn't my fault. It still takes a long time to get out. Chapter 3. I walk down the same street. There is a deep hole in the sidewalk. I see it is there. I still fall in. It is a habit. My eyes are open. I know where I am. It is my fault. I get out immediately. I walk around it. Chapter 4. I walk down the same street. There is a deep hole in the sidewalk. I walk around it. Chapter 5. I walk down another street. Wonderful poem to introduce to your clients as a therapeutic use of poetry, creating hope and optimism, and again conveying to our clients that we empower them and support them to be able to walk down another street or even just walk around that deep hole in the sidewalk. And then finally, if you would like a very impressionable TED Talk, Dr. Stephen Lewis. We don't often hear from men that have self-injure. Dr. Stephen Lewis is a former self-injurer himself. This became his area of expertise. And so he's the co-author of the book, Non-Suicidal Self-Injury. And this is his TED Talk, talking about his experiences with self-injury, especially if you work with any male clients that are self-injuring. This is definitely a TED Talk that you may want to share with them. And then finally, I've included all of these resources on your resource links document. I know the hour's gone by quick, but I hope this has been helpful to give you some starting points for assessing and treating NSSI. Check out all of your handouts. And I'm so grateful for you all being here. Thank you so much. And I'll see you next time. Bye-bye.